Hello, I'm Dr. Anthony Wheeler, and I'm literally telling you everything that you need to know about pathology. You're probably wondering why this child's cheeks are so rosy. She has fifth disease caused by Parvovirus. Interesting. We're going to go over that and much more. This section is Normocytic Anemia Pathology. Make sure you have your book, Medical School Pathology and Step 1 Review. It has everything in it that you need to know to do exceptionally well with your coursework, and importantly with Step 1. I know it's pass-fail now. Some people are getting a little lax. Yeah, don't let that be you. Keep me proud. Keep your parents proud. Don't fail. If you fail, I don't know. Better safe than sorry. Now, Normocytic anemia. Normocytic anemia is anemia with normal-sized red blood cells. That is 80 to 100 micrometers cubed. Here we have this child again with fifth disease. Those rosy cheeks is a classical gestalt finding for all the pediatricians out there. Now, other things can cause such rosy cheeks, just like being happy or something, being chilly outside. But for pathology purposes, you want to rule out a parvovirus infection. Normocytic anemia is typically due to raised peripheral destruction of the red blood cells or underproduction of red blood cells, such as with a parvovirus infection. The difference between these two causes can be determined by the reticulocyte count. Here in this image, we have a patient with normocytic anemia due to a G6PD deficiency following fava bean consumption. To the right, we have a peripheral blood smear of a patient that has paroxysmal nocturnal hemoglobinuria. Note that it causes normocytic anemia. And again, now we have another peripheral smear, but with this one, we have these strange sickle-celled red blood cells. Guess what condition this patient has? Sickle cell anemia, right? What organism are they protected from? Plasmodium falciparum, right? Again, normocytic anemia. We have a peripheral blood smear of Hereditary Spherocytosis. And this image here to the right with the 5 tubes shows different grades of hemolysis as assessed visually by a chemistry analyzer, which provides a quantification of the amount of hemoglobin in the sample as a hemolysis index. Interesting, right? This image is showing reticulocytes, specifically using the supravital stain of a smear of human blood from a patient with hemolytic anemia. The reticulocytes are the cells with the dark blue dots and curved linear structures. Okay, so buckle up because this is very, very important to know. We'll start with reticulocytes. Reticulocytes are young red blood cells released from the bone marrow. Here's the same image again, okay? It's important. Reticulocytes can be spotted on the blood smear as large cells with bluish cytoplasm. Reticulocytes appear blue due to the residual RNA present within them. A normal reticulocyte count is 1 to 2% of the red blood cell count. And RBCs usually have a life that is around 120 days. That's about 4 months. Reticulocytes are replaced about 1 to 2% of the red blood cells that are eliminated from circulation each day. Now, anemia causes a well-functioning marrow to raise the reticulocyte count to greater than 3%. In anemia, reticulocyte count is erroneously increased. A reduction in total RBCs artificially inflates the percentage of reticulocytes, which is how reticulocyte percentage is calculated. Reticulocyte count is corrected by dividing the hematocrit by 45 and multiplying the value obtained by 0.04. A corrected count greater than 3% indicates peripheral damage and a strong marrow response. A corrected count below 3% signifies underproduction and a poor marrow response. Peripheral red blood cell destruction is hemolysis or hemolysis. Hemolysis is characterized into two groups, either extravascular hemolysis or intravascular hemolysis, outside of the vessels or inside of the vessels. Both extravascular and intravascular hemolysis cause anemia and a healthy marrow response. The reticuloendothelial system is responsible for destroying red blood cells during extravascular hemolysis. The reticuloendothelial system includes the spleen, very important, as well as the liver and lymph nodes. Red blood cells are consumed by macrophages and broken down to hemoglobin. A breakdown of hemoglobin into amino acids then occurs. Heme is broken down into protoporphyrin and iron, with iron being recycled. Unconjugated bilirubin is produced when protoporphyrin is broken down. This bilirubin is then coupled to serum albumin and transported to the liver, where it is conjugated and excreted as bile. Clinical and laboratory findings of extravascular hemolysis include unconjugated bilirubin-related jaundice, right? Anemia, splenomegaly, you'll feel that on a physical exam or see it in imaging. Higher risk of bilirubin gallstones, and marrow hyperplasia with corrected reticulocyte count greater than 3%. In intravascular hemolysis, red blood cells within the vessels are destroyed. Clinical and laboratory findings of intravascular hemolysis include hemoglobinuria, hemoglobinuria, and hemosideruria. Now let's talk a bit about normocytic anemias with a predominant extravascular hemolysis. Hereditary spherocytosis. You know about this. Hereditary spherocytosis is an inherited defect of red blood cell cytoskeleton membrane tethering proteins. This image to the right shows a peripheral blood smear of a patient with hereditary spherocytosis. You see all the spherocytes? Note the lack of central pallor for the most part. Hereditary spherocytosis is most typically due to defects in spectrin, ankyrin, or band 1. Again, spectrin, ankyrin, or band 1. In hereditary spherocytosis, membrane blebs develop and disappear over time. Spherocytes or round cells are the result of membrane loss rather than disc-shaped cells. Spherocytes are less able to pass through the splenic sinusoids and are consumed by the cells there, which causes the anemia. Symptoms of hereditary spherocytosis include splenomegaly, jaundice due to unconjugated bilirubin, and gallstones. Laboratory findings in hereditary spherocytosis include spherocytes with loss of central pallor, Howell-Jolly bodies, which are fragments of nuclear material within the red blood cells, increased red blood cell distribution width at RDW will be increased, increased reticulocyte count, and increased bilirubin. Hereditary spherocytosis is diagnosed by an osmotic fragility test. You remember that test? Right? You know that. Hereditary spherocytosis is diagnosed by an osmotic fragility test, which in a hypotonic solution demonstrates increased spherocyte fragility. Aplastic crisis is more likely to occur in patients with hereditary spherocytosis when erythroid precursors are infected with Parvovirus B19. Wow, that would be a double whammy. Treatment of hereditary spherocytosis is a splenomegaly. Splenectomy, I should say. How jolly bodies are present after splenectomy. Moving on to sickle cell anemia. Very important topic. Sickle cell anemia is due to an abnormal mutated hemoglobin beta chain. Sickle cell anemia is inherited in an autosomal recessive fashion. Here on the right, you can see inheritance pattern for a sickle cell anemia, okay? Sickle cell anemia is caused by a valine being substituted for the normally occurring amino acid, which is glutamic acid. 10% of Americans with African ancestry carry the gene, probably as a result of its defense against falciparum malaria. Two defective beta genes cause sickle cell disease, which causes greater than 90% of RBCs to have hemoglobin S. Sickle cell disease is quite the process, okay? Make sure you got this. Deoxygenation of hemoglobin S causes the polymerization. Polymerization causes aggregates of sickle-shaped clusters. Hypoxemia, dehydration, and acidity all raise the chance of becoming ill. This image to the right shows a colored scanning electron microscope image of a sickle cell and other red blood cells. With sickle cell disease, hemoglobin F protects against sickling. High hemoglobin F at birth provides the young baby protection for the first few months of life. While moving through the microcirculation, cells repeatedly sickle and desickle, leading to issues associated with red blood cell membrane damage in our older patients. Take a look at this peripheral blood smear. See all those sickle-shaped red blood cells? Interesting. In sickle cell disease, red blood cells with broken down membranes are removed by extravascular hemolysis, utilizing the reticuloendothelial system, which causes anemia, jaundice with unconjugated hyperbilirubinemia, and elevated risk for bilirubin gallstones. Red blood cells with broken membranes dry, which causes hemolysis with diminished haptoglobin and target cells on the blood smear. Complications of sickle cell disease include massive erythroid hyperplasia that results in the expansion of hematopoiesis into the skull and facial bones, which is referred to chipmunk faces on x-rays. Vasoocclusion, dactylitis with enlarged hands and fingers, autosplenectomy because the spleen is constantly assaulted by these abnormal red blood cells and it shrinks and shrinks and shrinks. Another complication includes parvovirus-induced aplastic crisis, wow, another double whammy. Others include renal papillary necrosis, which causes proteinuria and severe hematuria, increased risk of infection with encapsulated bacterial pathogens, you know that from micro, as well as acute chest syndrome. Encapsulated bacterial pathogens that are known health risks for sickle cell disease patients include Haemophilus influenzae and Streptococcus pneumoniae. It's commonly asked about these conditions, but you know them. Streptococcus pneumoniae is the most common cause of death in children with sickle cell disease. It's very unfortunate. By the age of 5 years old, affected children should receive the Haemophilus vaccine. Infection is the most common cause of death in children with sickle cell disease. Acute chest syndrome is vasoocclusion of the pulmonary microcirculation. And acute chest syndrome is usually precipitated by pneumonia. Acute chest syndrome presents with shortness of breath, pulmonary infiltrates on the radiology, and chest pain. Acute chest syndrome is often precipitated by pneumonia infection. Acute chest syndrome is the primary complication of sickle cell disease that causes death in adult patients. One mutant chain and one normal chain make up the sickle cell trait. Results in RBCs with less than 50% hemoglobin S, which is hemoglobin A, is produced more effectively than hemoglobin S. Patients with sickle cell traits are typically asymptomatic with no anemia. In vivo red blood cells with less than 50% hemoglobin S do not sickle outside of the renal medulla. Sickling, which leads to microinfarctions, microscopic hematuria, and finally, a diminished ability to concentrate urine, is brought on by the extreme hypoxia and hypertonicity of the medulla. Laboratory findings of sickle cell anemia, or sickle cell disease and sickle cell trait, include, in sickle cell illness, but not in sickle cell trait, sickle cells and target cells can be identified on blood smears. Cells with any level of hemoglobin S get sickled when exposed to the metabisulfite screen, and this is true for both illness and trait. Hemoglobin electrophoresis provides evidence of hemoglobin S's presence and concentration, right? With the disease, 90% hemoglobin S, 8% hemoglobin F, 2% hemoglobin A2, and no hemoglobin A are characteristic findings on the hemoglobin electrophoresis. For the trait, you will typically see on hemoglobin electrophoresis 55% having hemoglobin A, 43% having hemoglobin S, and 2% having hemoglobin A2. Treatment of sickle cell disease is with hydroxyurea, which elevates the levels of hemoglobin F. Also, in practice, it's important to note that patients with sickle cell traits are usually asymptomatic. And it's also important to note that patients with sickle cell disease usually receive regularly scheduled red blood cell transfusions to get rid of the red blood cells that are sickling and to be given normal red blood cells. Now, hemoglobin C. Hemoglobin C is due to an autosomal recessive mutation in hemoglobin. In hemoglobin C, lysine takes the place of the regular glutamic acid. Hemoglobin C is less common than sickle cell disease. And due to extravascular hemolysis, moderate anemia is the initial symptom of hemoglobin C. Characteristic findings on hemoglobin C blood smears include a hemoglobin C crystals. All right, now let's talk about normocytic anemias with predominant intravascular hemolysis, such as paroxysmal nocturnal hemoglobinuria. Paroxysmal nocturnal hemoglobinuria is an acquired myeloid stem cell deficiency leading to the absence of glycosylphosphatidylinositol, GP1. Glycosylphosphatidylinositol protects cells from complement degradation with DAF and MERL. This GPI deficiency makes cells vulnerable to complement degradation. Blood cells and complement normally coexist in peace. By blocking C3 convertase, the decay accelerating factor, DAF, found on the surface of blood cells, guards against complement-mediated damage. GPI anchors DAF to the cell membrane, it's an anchoring protein. Lack of GPI results in a lack of DAF, which results in the cells becoming vulnerable to harm caused by the complement system. Here we have a peripheral smear from a patient with paroxysmal nocturnal hemoglobinuria. In PNH, intravascular hemolysis occurs sporadically, frequently while people are sleeping at night. And this is due to the shallow breathing during sleep, which leads to the development of mild respiratory acidosis, which activates complement. Platelets, white blood cells, and RBCs are lysed. Hemoglobinemia and hemoglobinuria, particularly in the morning, are caused by intravascular hemolysis, while hemocytinuria develops days following hemolysis. The glucose test is used to check for illness, and the acidified serum test or flow cytometry is used to check for the absence of CD55 on blood cells. CD55 is also DAF. Hepatic portal or cerebral vein thrombosis is the primary cause of death in patients with PNH that die due to PNH. Platelets that are destroyed discharge their cytoplasmic contents into the bloodstream, causing thrombosis. Complications of paroxysmal nocturnal hemoglobinuria include iron deficiency and acute myeloid leukemia. Iron deficiency anemia may be caused by continuous loss of hemoglobin in the urine. And acute myeloid leukemia occurs in 10% of patients with PNH. Here is an image of the various bone marrow biopsies from a patient with paroxysmal nocturnal hemoglobinuria. Now let's talk a bit about glucose 6-phosphate dehydrogenase deficiency. Glucose 6-phosphate dehydrogenase deficiency is an X-linked recessive disease caused by reduced G6PD half-life. The cells of patients with G6PD deficiency are vulnerable to oxidative stress. Don't eat those fava beans. Red blood cells are typically subjected to oxidative damage, especially from oxidants. Free radicals are normally neutralized by the antioxidant glutathione. However, during the process, it oxidizes. Reduced glutathione must be rebuilt using NADPH, which is a byproduct of G6PD. Absence of G6PD or deficient G6PD does not help replenish glutathione. In the absence of glutathione, free radicals cause oxidative injury. G6PD deficiency is associated with intravascular hemolysis. Now, there are two main types of G6PD deficiency. G6PD's mildly shortened half-life in the African form causes minor intravascular hemolysis and oxidative stress. G6PD's half-life is significantly shorter in the Mediterranean type, which causes significant intravascular hemolysis and oxidative stress. G6PD may be protective against falciparum malaria, which may be the cause of the high carrier frequency in both groups. Stress from oxidation causes Heinz bodies to form in patients with glucose-6-phosphate dehydrogenase deficiency. Causes of oxidative stress include, and you need to know these, fava beans, infections, and certain medications such as dapsone, primaquine, and sulfa medicines. Symptoms of G6PD deficiency include back discomfort and hemoglobinuria hours after being exposed to oxidative stress. On peripheral blood smears, you might see bite cells that are produced as a result of splenic macrophages removing the Heinz bodies from the RBCs. On the Heinz preparation, G6PD deficiency screen can be visualized because there's this precipitated hemoglobin that can only be seen with a special Heinz stain. And studies on enzymes show a lack, right? And this is typically performed weeks after hemolytic episodes resolves. Here we have representative images of IHC staining for glucose-6-phosphate dehydrogenase in a patient that had RCC. This is out of your scope, but just be aware that glucose-6-phosphate dehydrogenase is important, and we went over why it's important. It's also important for biochemistry. Now, this is within your wheelhouse. I know you love biochemistry. Can you see how G6PD deficiency affects various following downstream steps? Let's move on to immune hemolytic anemia. In immune hemolytic anemia, red blood cells are obliterated as they circulate through the body. Extravascular hemolysis typically occurs in the IgG-mediated illness. Warm agglutinin, which forms when IgG binds red blood cells in the relatively warm central body, causes spherocytes to form when splenic macrophages eat the antibody-coated red blood cells membrane. This can be associated with some medications, CLL, chronic lymphocytic leukemia, and the most prevalent cause, systemic lupus erythematous, classically as well with penicillin and cephalosporins. Drugs like penicillin that adhere to the red blood cell membranes may then cause the antibody to bind to the drug membrane complex. A drug may cause the formation of autoantibodies that bind self-antigens on the red blood cells, such as alpha-methyl-dopa. The problematic medicine must be stopped, along with steroids, IG, and if necessary, a splenectomy given as part of the treatment. In immune hemolytic anemia, Intravascular hemolysis typically occurs in diseases that are IgM mediated. During the relatively chilly temperature of the extremities, IgM binds red blood cells and fixes complement. This is linked to infectious mononucleosis and Mycoplasma pneumoniae. Immune hemolytic anemia is diagnosed with the Coombs test. You know that test. Direct or indirect testing are both possible. In immune hemolytic anemia, red blood cells with antibody coatings are confirmed by a direct Coombs test. Patient red blood cells are enhanced with anti-IgG. If red blood cells are already coated with antibodies, agglutination takes place. The most crucial test for immune hemolytic anemia is this one. The indirect Coombs test is used to verify if the patient's serum contains antibodies. The patient's serum is combined with test red blood cells and anti-IgG. If serum antibodies are present, agglutination takes place. Intravascular hemolysis that results from vascular pathology. Red blood cells are destroyed as they pass through the circulation. Iron deficiency anemia may occur with chronic hemolysis, and this occurs with prosthetic heart valves, aortic stenosis, and microthrombi, primarily due to physical changes, whether it be shearing from increased force through random strange valves or shearing of the red blood cells themselves, such as what happens with TTP or hemolytic uremic syndrome, DIC or HELP syndrome. Microthrombi produce schistocytes on the blood smear. Here we have the histologic sections of a marrow from a patient with immune hemolytic anemia. Let's discuss malaria a bit. This is an important topic. Malaria is a parasitic infection of red blood cells in liver with Plasmodium species. Malaria is transmitted by the female Anopheles mosquito. This image is just showing an electron microscope of a red blood cell affected by Plasmodium falciparum. The life cycle of Plasmodium includes red blood cell rupturing, which causes intravascular hemolysis and cyclical fever. Some types of Plasmodium to be aware of include Plasmodium falciparum, Plasmodium vivax, and Plasmodium ovale. Plasmodium falciparum causes daily fevers. Plasmodium vivax causes fevers every other day. Plasmodium ovale causes fevers every other day as well. The spleen consumes some red blood cells infected, which results in mixed extravascular hemolysis and splenomegaly. Here's a cartoon depicting some of the main symptoms of malaria. And here is a colorized electron micrograph showing the malaria parasite attached to a human red blood cell. Malaria can also result in stillbirths. As we see here, red blood cells that are anuclear, indicating a foreign nuclei from the parasite. This micrograph is taken from the placenta. Again, we have some sort of partially colorized electron microscope from a Plasmodium infection. Now let's talk a bit about anemia due to underproduction. Reduced production of red blood cells by the bone marrow, that is. Low corrected reticulocyte count is the defining feature. Causes of anemia due to underproduction include reduced erythropoietin, right? That makes sense. If there's no EPO, then the marrow is not going to be stimulated to produce more red blood cells. So reduced erythropoietin synthesis by the peritubular interstitial cells and renal failure, or bone marrow progenitor cells that have been harmed, which may result in anemia or pancytopenia, such as Parvovirus B19 infection. In the presence of pre-existing marrow states with stress, Parvovirus B19 infects the progenitor red cells, called pronormoblasts or pronormocytes, and momentarily halts erythropoiesis, resulting in severe anemia. Parvovirus B19 infection is usually fine and self-resolves without serious implications. Here's this young child again. You know that she has Fifth's disease, right? Due to Parvovirus B19 infection. Future pediatricians, be on the lookout for this. Now let's talk a bit about aplastic anemia. Pancytopenia with anemia, thrombocytopenia, and leukopenia, basically low red blood cell count or low hemoglobin or both, low platelets and low white blood cell count, with low reticulocyte count, is caused by damage to hematopoietic stem cells. Causes of aplastic anemia include drugs, certain chemicals, viral infections, or even autoimmune damage. A completely fatty marrow is usually what is seen on a bone marrow biopsy. So you'll have a bone marrow biopsy lacking any megakaryocytes and erythroid precursors, no myeloid precursors. It will just look like an empty marrow. Treatment of aplastic anemia involves stopping use of any causative medications and providing supportive treatment, whether that's transfusions or marrow-stimulating agents such as erythropoietin or GM-CSF or GCSF, what are those called? Filgastrum, pegfilgrastim, things like that to get the marrow producing. Certain idiopathic instances of aplastic anemia are caused by aberrant T cell activation and cytokine production. Thus, immunosuppression may be beneficial in those cases. And as a final resort, bone marrow transplantation may be necessary to treat aplastic anemia. Here we have three images, A, B, and C, from left to right. The top left one is normal. You would hope your bone marrow looks like that for all intents and purposes. You don't want the middle one because you just see sheets of basophilic cells that look somewhat monotonous. No production of erythroids, no production of myeloids. Don't see any megakaryocytes. Just see a bunch of abnormal, immature blasts. That's acute leukemia. The image to the far right is C, from a aplastic bone marrow. Note the scant cellularity compared to A. Note those globs of white, that's just fat. Aplastic anemia. Now let's get into the myelocytic process. A myelocytic process is a pathologic condition that takes the place of bone marrow, such as metastatic cancer, right? Pancytopenia is caused by poor hematopoiesis. And you made it. Bravo! Woo, that one was a doozy. You were on the right track. Wow, I can't believe you're going through all of this. You got a good head on your shoulders. You're so smart. I see why you're going into medicine. I see you. Great job. Keep up the good work. Keep making me proud. Keep making your family proud. Help your friends. Keep doing a good job. Happy studying. I'll see you later.